Hi, my name is Brian. I'm a current PGY1 pharmacy resident at Champlain Valley Physicians Hospital, part of the University of Vermont Health Network. Today I'll be discussing the impact of pharmacist-led transitions of care services on patient outcomes. By the end of our discussion today, you should be able to explain some of the general components that make up a typical meds-to-beds program. You should also be able to recognize some key elements that make a successful transitions of care service, as well as some commonly encountered important barriers to implementation of such services. And then lastly, for the majority of the presentation today, we will discuss some recent literature regarding the impact of specifically pharmacist-led transitions of care services on patient outcomes. To introduce the topic and just to provide some context for the discussion moving forward. So CMS defines transition of care simply as the movement of a patient from one setting of care to another. So this can be from any inpatient to outpatient service, or one outpatient to a different outpatient service. So hospitals, ambulatories, specialty care practices, long-term care, home health or rehab facilities. Any transition from a patient between these facilities constitutes a transition of care. And that includes a patient leaving the hospital and returning home or returning to any one of these facilities. Where a pharmacist might have an impact is really, being the medication expert on the healthcare team, is that focus on the medication aspect of transition of care, which can be a very, problemsome area. As we can see, non-adherence in general to chronic medications, according to the World Health Organization, can account for up to 50% of treatment failures, roughly 125,000 deaths, and up to 25% of all hospitalizations each year. Further, it's estimated that anywhere up to 4% of all hospital admissions are directly related to an adverse drug event, and up to 70% of these adverse drug events leading to hospitalizations are actually preventable. So this it really is the basis for why it's proposed that a pharmacist be involved in these pharmacist-led transition of care programs, because it's thought that we can have a significant impact on some of these aspects of patient care and prevent readmissions and prevent hospitalizations initially, improve adherence in the long term, and improve overall patient health, and essentially make these transitions of care as effective and efficient as possible. A trend that we've seen emerging in recent years is the adoption of these meds-to-beds programs by hospitals across the nation. Essentially, meds-to-beds is a collaborative sort of transitions of care service, pharmacy service in particular, that ensures that patients receive their discharge prescription medications when they're ready to leave the hospital. So that way this sort of eliminates any barriers to obtaining these medications once the patient is discharged and leaving the hospital. So they all work a little bit differently, but here at CVPH, the initial step is that when a patient is admitted, the nursing staff will assess patient interest, and if the patient is interested, they will manually enroll them in the electronic medical record. So we have an opt-in program here, whereas some other programs have an opt-out program where everybody is automatically enrolled and it's their choice to opt out. Once discharge prescriptions are written, they're going to be sent to the outpatient pharmacy on site. At that time, pharmacy staff will process and fill these discharge prescriptions as normal. They'll bill insurance, resolve any insurance issues or other issues that may arise before the patient is ready to be discharged. Once the patient is ready to be discharged, the nursing staff will communicate and coordinate the delivery of the medications with the pharmacy staff. At that time, pharmacy staff will deliver the discharge medications to the patient's bedside, and if necessary or if the patient wants it, they have the option to have a one-on-one private consultation with a pharmacist for any questions relating to their medications. Not exclusive to these meds-to-beds programs, but when we think about any transitions of care service in general, there's a number of barriers to implementation that are commonly encountered. One being insufficient staffing resources. So when we think about implementing a new service for patients, we have to either add responsibilities to existing employees, or it'll require the addition of a new employee, which may be difficult to justify financially. And then sort of tying off with that, financial limitations is also a big barrier to implementing such services, particularly when we think about pharmacy. So, lack of reimbursement for any non-dispensing aspects of pharmacy practice has been an ongoing struggle in that regard. And there's always going to be this ongoing need for justification of program self-sustainability as well as any revenue generation, so that you're able to acquire the funds and keep the program afloat. And then lastly, lack of communication is also a large barrier. And when we think about transition of care, it's very collaborative. So we have all these different disciplines working to ensure successful transitions of care for our patients. So lack of communications between the different disciplines, whether it be medicine, social work, nursing, or pharmacy, can be an issue, as well as making sure that the organization is aware of such services and is being educated on the services that are being provided. Now that we understand some of the barriers to implementing these services, then we want to think about what sort of elements actually make a successful transition of care service. So a few different things we can think about. So it's going to be multidisciplinary support and collaboration. So again, these services are going to be very collaborative in nature, and those that are successful incorporate, different disciplines of healthcare professionals. This includes administration and leadership, and you also get the support of the patient, family, and or caregivers, all being involved in this service being provided. When we think about implementing pharmacy transition to care services, those that are successful are going to effectively integrate the entire pharmacy team in their working of the process. So this includes not only pharmacists, but pharmacist extenders, which can be pharmacy students, interns, residents, or technicians, who can all share in some of the tasks and responsibilities for implementing the program. And then lastly, an important aspect, and what we'll be focusing on for the majority of the remainder of the presentation, is having data to justify the resources being used to run the service. So it's important to have solid data collection processes in place, so that you're able to actually review important metrics, whether it be readmissions, length of stay, ED visits, can be medication-related problems at medication reconciliation, disease-specific metrics, or you can even look at things like HCAHPS-related metrics or patient satisfaction to determine the overall success of the program and effectiveness. With that said, now for the remainder of the presentation, we'll take a look at some of the data supporting pharmacist-led transitions of care services and how it affects patient outcomes and what the benefit of these programs actually is. The first study we'll look at is titled The Effect of a Collaborative Pharmacist Hospital Care Transition Program on the Likelihood of 30-Day Readmission. This was published by the American Journal of Health System Pharmacists back in 2014. This was a retrospective cohort study that looked to evaluate the effect of implementing a collaborative pharmacist hospital care transition program on likelihood of 30-day readmission. They looked at any patient who was discharged from one of two acute care hospitals that were in the same hospital network, anyone who was discharged from these hospitals to home in this 2-year period from January 1st, 2010 through December 31st, 2011. They excluded any patients who were discharged to skilled nursing facilities or to hospice. Looking at the interventions, so that pharmacist hospital care transition program, it consisted of two main components, A being bedside delivery of any discharge medications upon patient discharge, and then B, follow-up telephone calls made by a pharmacist 2 to 3 days after discharge. And the primary outcome was claims-based evidence of readmission within 30 days. Taking a look here, we can see the components of their quote-unquote meds-to-beds program that they implemented, or their care transition program. So patients were initially informed of the program by receiving a one-page flyer in their admission packet. In addition, outpatient pharmacy staff actually performed rounds daily on the different units to enroll patients and gauge their interest in the program. they had an opt-in style program. Um, Before a patient was ready to be discharged, any prescriptions as well as the enrollment form were faxed to the outpatient pharmacy, and then they scheduled medication delivery as such. Medications were delivered by either a pharmacy technician or a pharmacist, and they were delivered within 1 to 3 hours of discharge. And then an interesting aspect of their program was that they actually implemented these follow-up calls made by the pharmacist. So all patients who actually received bedside medication delivery would get a call from a pharmacist within 72 hours. It was unscripted, and it just sort of assessed how the medication was going, address if they had any questions or anything like that, kind of see how the initial days of therapy had been for the patient. As for the results, over that 2-year study period, there's almost 20,000 patients accounting for more than 25,000 admissions. 72% of the patients were Black, 60% were female. Looking specifically at the intervention group when compared to the usual care group, these patients were less likely to be older, they were less likely to be Black, male, and they were also less likely to have Medicaid as their primary insurance. Compared to usual care, they had a shorter mean length of stay, and they also had fewer conditions or comorbid conditions. There was a total of 2,500 readmissions within 30 days of discharge, and when you looked at usual care versus intervention, the intervention group had significantly fewer readmissions within 30 days of discharge. As you can see, a rate of 9.5% in the usual care group versus the 5.0% in the intervention group. You can see the p-value less than 0.05 there. So for the primary outcome of readmission within 30 days of discharge, the usual care group actually had a 90% increased odds of readmission within 30 days compared to the intervention group. And you can see the adjusted odds ratio there, confidence interval. When they looked specifically and stratified it according to different covariates, there were some other factors that were also associated with readmission, and those being Black race, patients who had a longer length of stay, who had Medicaid as their primary insurance. Depending on the month of discharge, there was a significant difference in readmission. And then those patients who had a higher comorbidity count were also at an increased risk of readmission. In the study, they also performed this stratified analysis. So they stratified according to age, so those patients who are age 65 and older, and those who are less than age 65 years of age. So in the group that were 65 years or older, those in the usual care group actually had a 6-fold increased odds of readmission within 30 days versus the intervention group. So this was a significant increase in this group, and as we can see in those patients who are less than 65 years of age, even though there was an increased risk of readmission within 30 days in the usual care group, we can see that it was not as profound of a difference as we see with our older patients there. Similarly, when we looked at different covariates, some other factors that were also increased, also associated with a significantly increased likelihood of readmission were Black race, month of discharge, as well as, again, the count of comorbid conditions. So those who had more comorbid conditions had an increased risk of readmission. The study did have a number of limitations, one being its observational study design. So by design, we cannot infer causality from that. We can only observe the association between the different variables being studied. In addition, we only had claims data for the 2 hospitals that were included in the study. Therefore, they were unable to capture any readmissions for patients who were presenting to other hospitals or other hospital systems. For their readmission calculation, they used a readmission calculation that was closely mimicked the calculation used by CMS in their determination of readmission. So even though their patient population was neither restricted to specifically Medicare recipients nor to the targeted CMS conditions, specifically heart failure, acute MI, or pneumonia, they still utilized CMS's calculations when looking at readmission and when adjudicating this outcome. Looking at baseline characteristics, those in the intervention group did have some significant differences when we looked at compared to the usual care group. So we saw they had a shorter length of stay, they had fewer comorbid conditions, they were less likely to be older, black, or male, or have Medicaid as primary insurance. To kind of minimize this confounder, however, they did adjust for it, these various covariates by using logistic regression models as well as sensitivity analysis to kind of minimize the confounding factors there. And then lastly, there was some limited generalizability in the study as we only had data from these 2 hospitals in one region of the country that served a large proportion of patients who were either minorities and also those who had a low socioeconomic status. So we're unsure if this really can be applied to the general population across the country. The main takeaway from this study, though, was that we saw that the implementation of this care transition program that had 2 main parts, the bedside medication delivery portion as well as the follow-up telephone calls from a pharmacist, was associated with a significantly lower likelihood of readmission within 30 days of discharge. And an additional note we saw with the results was that the greatest benefit appeared to be observed in patients who were age 65 years and older. Moving on now to our next piece of evidence, we have a study entitled The Impact of an Advanced Pharmacy Practice Experience Student-Run Meds-to-Beds and Discharge Counseling Program on Quality of Care. This was published back in 2019, so a little bit more recent than our last study. Similar to the previous study, this was an observational retrospective cohort study. They looked to evaluate the impact of this Meds-to-Beds program on outcomes relevant to patients, healthcare providers, pharmacists, as well as administrators. We looked at all patients who were age 18 years or greater and were discharged from a medical or surgical floor between the given dates there. They excluded any patients who were not discharged to home, so this included anybody who went to a short-term rehabilitation facility, anybody discharged to palliative care, skilled nursing facilities, or long-term care were not included in this study. Patients who were pregnant, incarcerated, or who had been previously included in the study from a prior discharge, those admitted to an oncology service, or those with a primary cancer diagnosis based on ICD-9 codes were also excluded from the study. So again, the intervention here was simply the implementation of a Meds-to-Beds program, which, as we'll see, was primarily APPE student run, and we'll talk about this on the next couple slides. The primary outcome was, again, it was 30-day all-cause unplanned readmission rates. They also had some secondary outcomes they looked at, including rate of ED visits within 30 days of discharge, overall patient satisfaction based on HCAHPS scores, and then lastly, the overall financial impact on the outpatient pharmacy. As I mentioned on the previous slide, this Meds-to-Beds program was actually primarily led by APPE students on rotation at the hospital at the time. They stated that APPE student coverage was on weekdays between 11 a.m. and 7 p.m. So whenever there was not an APPE student available, the pharmacist or a resident actually fulfilled the role of the quote-unquote APPE student and performed their responsibilities and tasks. So the focus primarily was on delivery of medication with an appropriate discharge counseling and patient education. Again, mostly by the APPE students. However, when unavailable, this was also conducted by pharmacists or residents. Looking on the right side there, you can see the sort of general design and workflow of the program. So patients were initially identified by the unit staff. So this was either a care coordinator or a social worker actually gauging patient interest and enrolling them in the program. The outpatient pharmacy filled the prescriptions, and then the technicians, coordinated any payment. The APPE student, or if available, a pharmacist or resident, would counsel the patient on the new medications and then actually do documentation. In addition, similar like we saw with the previous study, they also incorporated this follow-up telephone call that was conducted by the APPE student 1 to 2 days after initial discharge. Overall, close to 300 patients were identified for evaluation, and 93 actually met exclusion criteria. Comparing the two groups at baseline, they had a median duration of stay of 3 days, but when we looked at the specific cohort control matched pairs that they had, those in the meds to beds group actually had a significantly longer length of stay compared to the usual care group or the control group. The primary diagnosis, the most common primary diagnosis that we saw were injury or poisoning, as well as diseases of the circulatory system. And at discharge, the average number of medications patients were going home with in the meds to beds program was 6, and the control group was 5. There was no difference between these groups, however. As for the results of the primary outcome, which again was 30-day all-cause unplanned readmission, we saw a non-significant reduction in these readmissions with the meds to beds program compared to the control group. So we can see it was an 8.7% of patients in the meds to beds group had readmission, whereas 10.3% of the control group had readmission. And you can see the median time to readmission there was 12.5 days and 11 days between the groups respectively. And again, this was a non-significant reduction. When they stratified specifically to patients who had 2 or more admissions within the previous 6 months, so trying to kind of nail down those patients who might be at higher risk of readmission, there was a relative risk reduction for readmission of 58%, 25% in the meds to beds group, and 60% risk of readmission in the control group. However, this again was not statistically significant. So we saw a non-significant reduction in this specific patient population as well. For the secondary outcome of rate of ED visits within 30 days of discharge, comparing the meds to beds group versus the control group, there was again, similar to the primary outcome, a non-significant reduction in this outcome. We saw 12% of patients in the meds to beds group and 18% of patients in the control group having an ED visit within 30 days of discharge. When we looked at time this first ED visit post-hospital discharge, however, it was significantly longer in the patients who were enrolled in the meds to beds group versus control. So these patients presented to the ED on average 11 days after hospital discharge compared with 7 days in the control group, and this was statistically significant. Breaking down the financial impact for the outpatient pharmacy, so the program was implemented hospital-wide in July of 2015, and you can see by the chart on the bottom there, you can see the significant increase in participation per month following the hospital-wide implementation of the program. From July to August, we can see the rate of meds to beds program increased from 2.2% to 8.7%. The average profit per prescription was $21, and the average prescriptions per patient was 3.3. So since implementation of the program, so this was over the course of the year, so November 2014 and November 2015, there was a total profit of $21,000 for the outpatient pharmacy. And lastly, for the third secondary outcome, being patient satisfaction, which was based on HCAHPS scores, there was no significant changes observed in any of the questions evaluated or any of the different components of the HCAHPS scoring system, as you can see listed there. The limitations in the study were twofold. So on one side, we think about the actual meds to beds program design limitations as well as the study design on the other hand. So when we think about the program design, participation in the study was limited by, the unit workers, so the care coordinators or the social workers on each unit were actually responsible for gauging patient interest and enrolling them in the program. So any turnover within the unit staff or any lack of program awareness posed for potential barriers for optimal utilization of the program. There was also variations and limitations in student knowledge, and this is important, because all these patients who were receiving the discharge counseling had it done by the API students who might have a varying degree of knowledge and comfort and skill set. So this may vary the overall results and the effectiveness of the implementation of the program. Looking at the study design, again, it was a retrospective study and it was only conducted at a single center. It had a small sample size. which was a convenience sample, and there was no power calculation. So all these together increased the risk for type 2 error. And then there was also a possible selection bias in that patients were more likely to be enrolled by unit staff if they had a history of frequent admissions or they had a longer duration of stay. And this indicates that they possibly may have included sicker patients who were more likely to be readmitted. So this may be overestimating the effects of the actual program itself on the general hospital population. In conclusion, the implementation of an API student-run Meds-to-Beds program in this study, when compared to control group, resulted in a non-significant reduction in 30 days all-cause unplanned readmission, as well as a non-significant reduction in rate of ED visits 30 days following hospital discharge. As we saw with this outcome, there was also a significantly longer time to ED visit following discharge in the Meds-to-Beds group compared to the control group. Looking at patient satisfaction, there was no difference between the groups according to HCAHPS scores, and then we did see there was a direct financial benefit to the outpatient pharmacy from implementing this API student-run Meds-to-Beds program. So just some future directions, we want to think about what is the overall economic impact not only to the outpatient pharmacy itself, but to the hospital and the hospital system, who has to eat the costs of readmission. And if there's any difference in these readmission rates, how is that affecting the overall economic burden to the hospital? And how is the hospital potentially benefiting from a Meds-to-Beds program such as this one in this study? In addition, because it was a relatively newly implemented program, they needed further follow-up to actually determine if there was a significant reduction in readmission, which may be more evident as time goes on and more patients are enrolled in the program. In the third and final study we'll talk about today, we'll focus more on the economic side of things and focus on the value of pharmacist-led medication reconciliation for reducing medication errors after hospital discharge. So whereas in the previous two studies we saw the implementation of these Meds-to-Beds type programs on patient outcomes and clinical outcomes, now we'll shift towards the economic impact, keeping in mind that we're looking specifically at the medication reconciliation portion of hospital discharge, not necessarily the bedside medication delivery. So this was a pretty interesting study, and it was a bit different than your typical randomized controlled trial or retrospective cohort study. This was actually a simulation-based cost-benefit analysis. It was a two-part discrete event simulation. The purpose was to estimate and compare the economic value of three different strategies at hospital discharge. And the three interventions were going to be usual care, which was your no intervention. The second was a non-targeted pharmacist-led medication reconciliation intervention for all patients. And then lastly, you had targeted pharmacist-led medication reconciliation intervention only for patients who are at high risk for adverse drug events, or ADEs. They used a hypothetical simulated cohort that was assumed to have characteristics that were similar to populations in previous studies that the authors used as the basis for their assumptions about event probabilities. So specifically, their patient population, the characteristics closely mimic those in the patients in the pill CVD study, and we'll talk about that on the next slide in a little bit more detail. As far as the overall approach, so they used a cost-benefit analysis framework, and there was an analysis that was conducted from the perspective of a hospital that was at risk for any added cost of any intervention, as well as the savings from avoiding any HRUs, which we'll talk about, due to preventable ADEs. So there was sort of two parts. So one, the first step was that the model estimated the incidence of medication discrepancies, preventable ADEs, as well as their associated major health resource utilization. So this is the HRU. So this essentially encompasses ED visits and rehospitalizations. And with this, also estimated the overall costs. And we'll talk about the different type of costs and how they were actually estimated. And then secondly, the simulation used this distribution of outcomes from the initial phase to compare the impact of these three different interventions on the overall costs. So again, the patient population was this simulated cohort that was assumed to be similar to the population from the pill CBD randomized controlled trial, which was a trial consisting of close to 900 patients who were hospitalized with ACS, or acute decompensated heart failure. In this study, patients were randomized to receive either pharmacist-led intervention, which consisted of med-rec, patient counseling, as well as telephone follow-up at discharge, or usual care, which was no intervention. So the mean age in the simulated cohort was 60 years. The median, or the patients in this cohort were assumed to have a median of 14 years of education, similar to that in the pill CBD trial. 60% were male, 10% were deemed to have inadequate health literacy, 8.7% were deemed to have marginal health literacy, and then close to 12% had some level of cognitive impairment. Looking at the primary diagnoses, so about 2/3 of the patients were hospitalized with ACS, close to 1/3 were hospitalized with acute heart failure, and then 10% of the patients had a hospitalization due to both ACS and acute heart failure. So just a quick definition that they used for adverse drug events, or ADEs. They looked at specifically preventable ADEs, so medication discrepancies that were associated with harm, and potential ADEs were considered any medication discrepancy that was not associated with harm but had the possibility to be associated with harm. Further, these ADEs were classified into those that were either life-threatening, serious, or significant. They also considered non-significant, but this was kind of scratched because by definition, any ADE that's non-significant by definition cannot be a medication discrepancy. So this was removed from the further stratification of these ADEs in this study. So in order to estimate medication discrepancies and subsequent events, the incidence of medication discrepancies, preventable ADEs, and potential ADEs for patients who are not undergoing reconciliation, so for that non-intervention group, were estimated using the actual distribution of these events in the control arm of the pill CBD study. So those patients who did not undergo any intervention, they looked at these specific rates of these events in order to estimate that in this study and determine the cost off of that. So the proportion of patients who had rehospitalizations, ED visits, or both events was based on observed rates in both the pill CBD trial, and they also looked at another large randomized control trial to estimate the overall incidence of these events. They assumed that the intervention could reduce risk of rehospitalization due to preventable ADEs by 52%, and this was based on compiling results from 4 different published trials of at least moderate methodological quality that looked at the effectiveness of medication reconciliation, and they averaged essentially the overall effectiveness in these 4 studies to determine that medication reconciliation at discharge was roughly 52% effective at reducing the risk of rehospitalization due to preventable ADEs. When it came to estimating costs, the average cost per rehospitalization was based on estimates from the Agency for Health Research and Quality. Cost per ED visit was based upon estimated charges that were generated in the same report from the agency. And then intervention costs were calculated using estimated average pharmacist time per reconciliation, as well as average pharmacist salary and benefit payments to pharmacists and pharmacy technicians. As for the results in the usual care group, so those who did not receive any intervention, so in a cohort of 10,000 patients not receiving any pharmacist-led med-rec, they estimated that 5,000 would have at least one medication discrepancy within first 30 days after hospital discharge, which would result in 5,000 potential ADEs and 3,800 preventable ADEs. thus leading to 421 rehospitalizations and 496 ED visits. So in the usual care group, the average cost of a preventable ADEs was estimated to be $472 per patient in the usual care strategy. Now for the second intervention, which again was a medication reconciliation for all patients, so this non-targeted approach, and like we mentioned before, assuming that pharmacist-led med-rec at hospital discharge reduced med errors by 52%, this would result in 199 rehospitalizations and 215 ED visits. So again, this is simply a 52% reduction of the event rates that we saw in the usual care group on the previous slide. Just reduce that by 52%, and this resulted in an estimated overall cost of $266 per patient. And of note, this does include the cost of medication reconciliation, about $39 per patient. So overall, performing med-rec for all patients at hospital discharge would result in a significant net benefit of $206 per patient. And lastly, the third intervention, that targeted approach, so medication reconciliation for targeted patients who were assumed to be high risk of readmission. So they used a hypothetical assessment tool and assumed a 70% sensitivity, 70% specificity of this screening tool to identify those who are at risk for preventable ADEs. And the net benefit from targeting med-rec in these patients was $146 per patient. So this was not superior to the savings from the non-targeted approach. However, they did do a couple different adjustments with the sensitivity and specificity of the tool, and they found that if they used a tool that was 100% sensitive and 100% specific, the net benefit could actually be as high as $232 per patient, which would exceed that of the non-targeted approach and the med-rec for the whole population. Thinking about limitations of this study, there really are few studies that have shown a direct impact of med-rec interventions on these post-discharge health resource utilizations. So again, readmissions or ED visits. So essentially the model was based on a chain of events that assumed any medication discrepancy would lead to a post-discharge ADE and thus further use health resource utilization and increased costs. The model was also based on studies that showed reduction in these discrepancies and some downstream events. So therefore, the estimates of the effectiveness on patient outcomes may not be necessarily accurate to the full extent. And then studies used to derive the estimates, the base case estimates in the usual care group were based on specific patient populations. So this significantly limits the generalizability of the results to other patient populations or other care settings. But overall, the study found that pharmacist-led med-rec at hospital discharge can be a cost-saving strategy compared with usual care. The net benefit of this intervention can be enhanced if we implement these highly sensitive screening tools for patients at high risk for post-discharge ADEs. And then, given what we know really and the limitation in the current knowledge base, future studies should focus on making a more direct link between these interventions and these pharmacist-led interventions and reducing post-discharge HRU in order to increase the precision of any cost-benefit estimate in the future. So to sort of summarize what we discussed today, so we talked about successful transition of care, not only pharmacy services, but transition of care services in general, being built upon a strong multidisciplinary collaboration and support from multiple disciplines, as well as the appropriate integration of pharmacy team consisting of not only pharmacists but your pharmacy extenders as well, and then having processes in place to appropriately collect outcomes data in order to justify your service moving forward is also important and are key components to maintaining successful transition of care services. On the other hand, we have common barriers we see when implementing such services being staffing and financial limitations and really not having the funding available, as well as a lack of communication between various disciplines and the various pieces of the program as being the most cited barriers to implementing these transitions of care programs. We talked about Meds to Beds being a specific pharmacy care transition program, and we talked about a couple different studies that showed these programs actually improve patient outcomes. And then in the third study we looked at, when we think about other, pharmacist-led care transition services, so in that case it was the discharge medication reconciliation, we saw that it can be potentially very financially beneficial to the institution. So altogether, we see that these transition of care pharmacy services, when implemented appropriately, have the potential to not only improve patient outcomes, but lead to economic benefit for the hospital as a whole. And with that, we will conclude our discussion for today. Thank you guys for joining me, and as always, if you have any questions, comments, or concerns, feel free to either shoot me an email. Again, my email is on the first slide of the presentation, or feel free to leave a comment down below, and I'll get back to you as soon as I can. Thanks again.